Welcome to Medic Life, a video podcast for EMS professionals with your host, John Newton.
This evening, we're going to be talking with Dr. Adam Scioli, who is a licensed psychiatrist. We're going to be talking about PTSD, specifically in EMS. Before we get started, guys, I just want to let you know that I do appreciate you guys coming and hanging out with us here at Medic Life. I want to hear from you guys, so if you can't be here live, you can always follow us on our live episodes just by watching YouTube. You can send in those questions, those of you who are watching, to JNewton_DCME. That's on Twitter, so that's the old @ symbol there in front of it. And you can even put comments in the little chat of your of the YouTube. And hey, hello. So we're going to get started here, and Dr. Scioli, go ahead and introduce yourself. Tell us what you do there, sir, and good evening.
Good evening, John. Thanks for having me on Medic Life. It's a pleasure to be with you all tonight. My name is Dr. Adam Scioli. I'm a psychiatrist in Pennsylvania. I specialize in the diagnosis and treatment of co-occurring substance use disorders and mental health problems.
Awesome. So thanks for hanging out with us tonight and being my guest, and I appreciate you doing this. Welcome to those of you who have just joined us. We are actually talking about PTSD in EMS, and we're just getting started. So what I would like for you to do for us, because I honestly say the idea for this show came to me after talking to some students and starting to see things in the news. I've read articles recently. There's just been numerous articles about PTSD and EMS. I honestly did not realize it was that big of an issue. I knew that PTSD was a big issue with our military, but I didn't realize that it had become such an issue that we were having so many people who were actually committing suicide. I actually had someone tell me recently that they've had like 10 people in I think it was like I can't remember if it was Denver or if it was Chicago, in EMS that's actually committed suicide, and it's related to EMS. So maybe if you could kind of I guess we'll start at the beginning and maybe describe to us some of the pathophysiology associated with PTSD, from the clinical aspect.
Sure, John. And you know, suicide is entirely, we could spend another half an hour entirely alone on suicide, but the facts are that PTSD is a setup for suicide. And you're correct in mentioning that most of what we know about PTSD comes from the trauma literature stemming from the war theater. And it makes perfect sense that first responders, particularly police officers, firefighters, and EMT paramedics, would suffer some of the same sequelae after exposure to chronic traumatic events. PTSD is in the DSM-5 under stress and trauma disorders now, and what a PTSD diagnosis requires, of course, is exposure to a trauma. Now, that exposure can be actual or threatened, and there are a number of different criteria that one has to meet in order to be diagnosed with PTSD.
What do you mean by threatened? Can you elaborate on that a little bit? That one's a new one on me.
Sure. So the diagnosis has changed a little bit over the last couple of years with the introduction of the DSM-5 from DSM-4. Of course, that's a diagnostic and statistical manual of basically the psychiatry Bible. Exposure is the key word here. And the exposure has to result from one or more scenarios in which you've either actually experienced a traumatic event yourself or witnessed a traumatic event. And of course, emergency medical technicians and paramedics fall into both of those categories. Oftentimes, they're witnessing the aftermaths of a traumatic event, And unfortunately, oftentimes they are actually part of the traumatic experience.
So, I guess we know as clinicians some of the things that we should kind of be looking for, but you know, the things we're taught in school about how to deal with our psych patients. But we don't often talk about how we should look at each other as our peer group, our other EMTs, our other paramedics. It's almost a thing that we don't really want to talk about. It's that if you don't talk about it, it's not real, it's not happening. So what are some of the things that maybe we should look at for our, not only our coworkers but ourselves, to help kind of say, okay, maybe I'm starting to show some of the signs and symptoms. What should I be looking for?
That's a good question, John, and I think endemic in medicine and pre-hospital medicine is this mentality that we have to maintain our composure under any and all circumstances. So in order to be a successful paramedic, you really have to be self-efficacious. And the culture within EMS and pre-hospital medicine in particular is that we cannot show weakness. And the way we define weakness sometimes is asking for help. So we almost set ourselves up to be superhuman. The fact is that we can be trained to take care of events that other people would not be able to function witnessing or being around, but that doesn't take away the human element of us. We all are expected to react to traumatic events in a similar way. So it's very unusual for someone to see the sort of events that paramedics see and not have some emotional reaction. So signs and symptoms that your colleague might be experiencing post-traumatic stress disorder would be things like isolation, not wanting to talk about the particular event, maybe talking about it and pretending and saying that had no effect on me whatsoever. That would be a red flag. Some of the other things that you might begin to recognize are signs of aggression. It's not uncommon for people who experience PTSD to fall into one of two categories, either the isolative, depressed sort of persona, or the more angry, irritable, and aggressive persona. So either extremes can be red flags. Certainly there's a tremendous correlation between PTSD and substance use disorders. So if you notice your partner or colleagues suddenly coming in smelling like alcohol or retreating to the bar after work, that might be a sign that there's a problem as well. I think in the general population, the substance use disorders, about 8% to 25% of the population will suffer from substance use disorders. When you're talking about people with PTSD, that number can go as high as 43%, but usually ranges between 20 and 40%. So those are some of the signs that you might be looking for.
So in this culture of EMS, there's two things, and since you said the whole stress factor and then substance abuse, we do, I hate to say this about my peers, myself, a lot of times we do seek that, I guess, camaraderie, that communion through, like you said, we leave work, where do we go? We go to the bar, we drink, we party, and that's kind of how we let off steam. So I guess one question for you is, how do we differentiate in between what we consider recreational, our community substance abuse, and when we put alcohol in that substance abuse category, maybe we should separate it. And the other question is the stress factor of working multiple jobs and people just being tired all the time, if you work night shifts, poor sleep, how does that, or how do we kind of cue in and go, okay, this is stress from sleep, from multiple jobs work, this is PTSD, or is this kind of like an outlier for the beginnings of PTSD because of this related stress?
Yeah, you hit on a couple really key points, John, as usual. You nailed it. People that are in EMS tend to have 1, 2, 3 jobs. They work shift work. Sometimes someone like yourself will be on an ambulance during the day, a helicopter in the evening, and then overnight you might be doing a podcast or a webcast like this,
Yeah.
or teaching for distance CME. So I think what you're talking about, the first example that you're giving is sort of a burnout phenomenon, and certainly burnout can lead to PTSD, but they are two different phenomena. At the end stage of burnout would be somebody who doesn't really experience any satisfaction from their job, and certainly lack of sleep, different shift differentials, low pay, conflict with supervisors, and constant stress can set you up for burnout. Burnout, again, in and of itself, would be a setup for PTSD. What you're looking at with PTSD is basic coping mechanisms that have been overwhelmed. So it's not that you don't have the coping mechanisms, it's that you are no longer able to utilize the coping mechanisms to overcome the trauma that you've been experienced to. And you mentioned camaraderie, and I think that that's actually the key to the treatment of PTSD. We can use the EMS culture of camaraderie to our advantage and use the brotherhood as a way to express our feelings, which we're not used to doing. It doesn't have to be out in the open, but it can certainly be behind closed doors in the brotherhood or sisterhood that we're accustomed to, sharing experience, talking about the events, letting people know how it affected you, and that's really what we're looking at now is more along the lines of resiliency training, and I think the camaraderie plays right into that resilience. It's when we start to criticize one another for having feelings and calling it a weakness, and that's when we get into trouble, and that's I'm hoping that that's part of the culture that we're stepping away from as this topic is becoming more prevalent.
I think back as we're having this conversation, and I don't know if I want to lay on the couch, as they say, in front of everybody here, but I think back over my 20-plus years in EMS, from military experience to, some fire service, and then, riding the ambulance for a number of years. And I think about, you were talking about burnout, and I know I was there. I can remember those days. I've had supervisors go, "Look, John, we like you, the patients like you, dude, you got to go home. It's time to go home. Don't come back for a couple days. You're like burning at both ends." And I remember those days, but I often wonder if maybe there was a little PTSD in there, and I wonder if maybe some of my coping mechanisms, like taking days off. The patients like you, dude, you got to go home. It's time to go home. Don't come back for a couple days. You're like burning at both ends. And hold on. Sorry.
That's okay.
Apparently I didn't set it where it would mute people automatically when they logged in, so it's getting the feedback. But yeah, so I wonder if some of those, and maybe you can tell me if some of these coping mechanisms are good coping mechanisms. The kind of separating yourself from your job, taking those few days off, and I know it's kind of hard for some people because we really can't afford to, but is it, the whole let's get away from technology, let's just, is it good to be by yourself, or do you think it's better to find someone to talk to, that person you trust, maybe a medical professional like yourself, or I don't know. What is your guess on that?
I think that there are healthy coping strategies, adaptive coping strategies, and maladaptive coping strategies. And there's a gray area in some of those coping strategies between the adaptive and the maladaptive. For example, EMS culture, the dark humor, the black humor, is kind of a defense against the nasty side of the world that you all see, and in medicine in particular. And sometimes that can actually be a positive coping mechanism if it's understood to be exactly what it is, which is a defense against the pain that you encounter every day. I typically, I would typically say that some of the positive coping mechanisms that you talk about, that you mentioned, were taking a time out when your supervisor said to you, John, you need to go home. I think that that should be a scheduled part of every medic's work week. If you have an exhausting work week, I think scheduling that day off in between particularly stressful shifts is a great idea. Everybody needs to catch up on sleep. Everybody needs to decompress. Whether or not you see a psychotherapist is entirely up to you, but I think that it's important for those services to be available to your service. And these employee assistance programs are not one size fits all. I think it's important for an employee assistance program that deals with paramedics, firefighters, and police officers to recognize and have some understanding of what it is that you guys go through. So if you're a supervisor and you're looking into an employee assistance program to send your personnel to a mental health provider, it would be important for you to know who that person is and to make sure they understand the culture of your department and of your profession. Invite them out for a ride along. Invite them to the the ambulance house or wherever your unit is. See how they fit in. See if they understand the way you guys cope with stress.
I will say that I think my personal experience, and I don't know, maybe some of you guys can chime in that are hanging out there and watching, and maybe let us know what your experience is. But in my personal experience, most of the care that is being offered is often usually only offered in relationship to some big incident. I can just remember one incident. I ran a mass casualty incident. It was it made national news, and it was a big bus wreck of a baseball team and at a college level, and a lot of folks died. There were some folks who were seriously injured, and I remember them talking about it, but it wasn't like mandatory. It was like, hey, if you want to talk to somebody, you can talk to somebody. If not, there's calls waiting, kind of thing. It wasn't the, hey, we're going to come in, we're going to sit down and talk about this, what we did, what we didn't do. And I don't want to call the agency's name because I think it was still the whole situation was handled well, but at the same time, I often wonder, and that's not just that agency. Other agencies do the similar thing. If it might be better if we make it mandatory for people to go and sit down and talk to somebody. I don't know. What do you think? What does everybody think about that? Those who are hanging out, whatever.
I think, John, that where we're headed lately is rather than being reactive, being proactive about this. So the debriefing days are kind of in the past, and I think what we need to focus more on is getting people to understand what it is that they're likely to face when they take a job as a paramedic, when they take a job as a firefighter, when they take a job as a police officer, and educating them on coping mechanisms and the concept of resilience and camaraderie so that when they face that, they know what tools are available to them. I think if we try to do that after the fact, it's oftentimes too late.
Okay, so I guess at this point I just want to pause briefly and I guess kind of recap what we've been talking about for those of you who have just joined us. We've been going for about 15-20 minutes or so. I'm here with Dr. Adam Scioli, who is a licensed psychiatrist in Pennsylvania. And we're talking about PTSD and EMS. We've kind of talked a little bit about some of the patho, some of the things that we should be looking for, not just for our patients, but for our coworkers, and even for ourselves, and some of those coping mechanisms.